in the joint response to the AAR, government and partners embraced that vision. And one of the things that they saw was the academic health science networks playing a really key role. So the AHSNs had already been incepted for a few years, and they'd really embedded themselves into their local health economies. They'd made networks, they were really respected by clinical communities, innovators found them really useful resources. So the AAR saw them as a key player in that field and really wanted to build on the strengths that we already had. So this is where Innovation Exchange's idea came about. And it was broadly 3 outcomes that we were trying to achieve. The first was about defining a set of core functions. So we had 15 organizations who were really useful in their different areas, but who all had kind of a variable service offer. They'd all developed something that fit their local population. And looking back, we started to realize that we probably needed a UK national offer that we could talk about. Something that we could say, and you walk into your local AHSN, at a minimum, here's a core. You might have additional features based on local need, but we can be confident that we are having this one core offer. We also wanted that core offer to be founded in best practice, so we needed the AHSNs to talk to one another and to partners to start to say, this is actually the most impactful approach to be taking. The second thing that we wanted to do was to increase the collaboration and coordination between the 15. So the AHSNs had already taken steps forward to kind of work together on national programs like the NHS Innovation Accelerator, and we just wanted to do that at a much greater scale. We wanted them to knowledge share about the products they were working with, the different approaches they were taking. We wanted it to be that if a stakeholder approached a local AHSN, they really accessed the whole skills and expertise of the entire network, not just your local AHSN. And then the third outcome that we were striving for was better coordination and collaboration between local and national. So the AHSNs, we really wanted to become the voice that was on the ground and a route in to speak to national decision makers, particularly with the new kind of integrated health system that we were trying to establish. So the AAR also developed what's called the Accelerated Access Collaborative that brings together senior decision makers from across the health system. And really what it was about was at the kind of lower level, you have 15 interconnected AHSNs who are speaking to one another, who are sharing information, products, passing things back and forth. Then you have a kind of cohesive AHSN network who has a national offer. And then sitting above it, you have an Accelerated Access Collaborative who's the national offer plus senior backing. And we wanted it to be that if an innovator came in at any level, they were finding the appropriate level of support. So there's an ability to kind of pass innovation up if we thought it was nationally significant, and to pass innovation down where you thought it needed kind of specialized or local support. So this is kind of just pitching how the AHSNs fit into that wider picture. And just quickly to mention, since the AAR, we've also had the Life Sciences Industrial Strategy, which reinforced that this is really the unique selling point of the UK if we can achieve this vision. So I think that gives you a bit of context.
Thanks, Tash. So as a clinician, one of the reasons that I get involved with academic health science networks was, an immense frustration about if you know that something's better, how do you actually make it happen? And that's really difficult because the NHS doesn't automatically teach you the skills to do those things. You spend 20, 30 years learning about, clinical needs and how you manage patients, but you don't actually get taught how to change things and how to make that sustainable and how to make that spread. And so I think, one of the great visions for the academic health science group as a network is the ability to do that locally, to take the lessons from it and then to spread that out as effectively, as rapidly as possible. And as you start to do that and see those pockets of change, we as a system have to start to think about, well, what are the mechanisms that we can use to create a common language between us all so that people know what we're talking about, common points of entry between us all. So over the next 40 minutes or so, hopefully we'll start to get a flavour about some of those. Within this new commission for academic health science networks, we've identified really 4 areas where we feel that we can provide greatest value that we'll all be delivering on. And so these core functions are listed in these slides. Now, as much as we need to have a sort of common standard about what we're doing, there is also, I think, a great opportunity for us to continue to be creative and curious within our own regions. Because a lot of this is being receptive to your local place, about your local communities, about what they actually need and want, and doing that sort of needs analysis both at a regional level and then tying that in with what's important nationally and sometimes indeed internationally is really important. So as an example, this has to be aligned with other things that are going on through the innovation agenda throughout the NHS. And so we used, for example, in the development of the NHS Innovation Accelerator needs, conversations with local systems and STPs about what are the priorities for the NHS within different regions and what are some of the solutions that we might want to think about as we start to create them. And all of the 15 HSNs are really embedded very well within their local systems, both within STPs and within integrated care systems. So that connectivity into the system is really, really critical for us to develop something that is comprehensive and sustainable. One example that I thought was a nice one to share is some work that we've been doing in collaboration with Celgene. And some of the learning points from this was that, you know, we recognise that when you identify an area, so quite a lot of our systems were looking at dermatology care pathways. Those clinicians clearly have ideas, they clearly know what they want to do, but that change management process and sometimes the technical skills about how you do it may be difficult for them because they don't have them themselves or difficult to access. And actually working with industry who more and more are becoming much more receptive to this idea about joint working going beyond simply selling of a product means that they can offer and share some of the great resources that they have. And we've seen examples of that, and that can sometimes be quite simple things like project management, but sometimes it can be access to quite sophisticated data analytics or to health economics, which for a particular region they might not have. So I think that sort of bringing together industry and the NHS is something that we have to think about. How do we actually do that in practice? And this programme, one of the other things that it's done is that it created a new framework for creating expressions of interest, creating quite a transparent process with a very clear governance process, so that we were creating that dialogue between industry, so we knew what both were offering and what both could do. And I think going forward, that's the sort of standard that we want to try and roll out. And for me, the place-based aspect of what we're delivering, despite having common standards being important, about how you can be receptive to your local needs is so important. And another example, so within London, we have a current Wave 1 testbed programme based in outer northeast London. And the AHSNs within London are supporting that. And one example which I think shows the power of relationships is that we've helped to look at how we can improve anticoagulation and atrial fibrillation to reduce strokes, and working with a technology company with AliveCore has been important, but that's only a relatively small part in the change process. And actually, how you can take clinical leaders and work with them to teach them the skills and implement new pathways of care has been critically important. And you have to spend a lot of time as part of the evaluation process finding out, is it likely that these things are going to land well? Because if you start to get the signals from those conversations that they're not, you then have to start to think about other solutions. So in this particular example, we would go to certain areas where primary care were really quite resistant to the idea of implementing these because they were frightened that it was going to simply increase their workload. Now, you can sometimes overcome that, or sometimes you can look at alternative solutions. So this group were able to actually go further upstream, start to create a new workforce with counter assistants and pharmacies, retrain them, set up one-stop clinics, and then create a mechanism to implement change that didn't actually impact negatively on primary care or GP practices. And the outcome of that was that they were able to take what's clearly the most important outcome. How long does it take from finding out someone's got a problem to actually putting them on the correct treatment, from an average of 12 weeks to 2 weeks? And that work's now being shared across the system. We also think that this programme of work is a great opportunity to link it in with some of our other work that we do with our NHS commissioners. So NHS England, who have recommissioned us for another 5-year licence cycle, we're looking at rolling out national programmes of work. So atrial fibrillation is one of the pathways of work where we're putting innovation into different aspects of that. But we have a number of other different programmes which really cross the spectrum of need in the NHS, whether that be from how we can prevent cerebral palsy in newborns, how we can look at optimisation of medicine pathways around transfers of care and pincer, community musculoskeletal programmes, mental health programmes, working beyond what we would regard as normal NHS, so working with police forces and others to make sure that people join the right pathways and a pathway on emergency laparotomies. So I think that this fits really well with our ambition and the alignment about how we can help the system. And I feel very confident that once we get through the language and the understanding about what we have to deliver, we can work with everyone here to make that a reality. So I'm going to pass on to Lorna now, who's going to talk through some other examples.
Thanks, Charlie. Before I start, can I just have a quick show of hands? Does anybody in the room work within an AHSN? Okay, so quite a few. Anybody from industry, business side? Couple. And then within the system? Okay, great, thank you. That helps me frame things a little bit. So Charlie's described the 4 objectives that we're all going to be working to under this new commission with OLS. And I just wanted to give you a little bit of a flavour of how the 15 of us are going to move forward with that, because as Tash said, you know, we've all evolved into slightly different organisations, not least because we've got very different health economies and local economies that we serve. And added to that, you know, the innovation exchanges are not going to be 15 blueprints of the same programmes locally. We're all doing different initiatives, different activities, but importantly, we'll learn from each other. We'll learn what's working really well, and we'll learn, adapt and adopt within our regions from each other those best practices as they mature. So one thing that's common to all of us is that we are going to be working across our regional systems. We're working with our STPs, with our ICSs, to really do some detailed work on their priorities, their needs, and how innovation might be able to support the change that they want to implement. So we'll be working with the service side, with NHS and health and social care providers and commissioners, but importantly we'll also be working with the frontline clinicians, the system leaders trying to drive and implement those changes, and the patients and carers. And we've got a number of different initiatives across the 15 of us to help us do that. Some of us have recruited new teams, new people embedded within the AHSNs. We call them different things. They have different job titles. So we've got system navigators. We've got, in our region, that's what we're calling them. In the southwest, they're regional intelligence analysts. But importantly, the role is the same. These are people that are focused on working with our local systems, STPs and leaders to understand and identify those key needs and priorities. Some are establishing innovation hubs, and some of these are physical spaces where people can come together and really kind of work through in detail, pull apart the problems, the needs, and really articulate those in a cohesive and comprehensive and agreed way across the system, that we can then inform our industry partners and innovators about those needs so that they can think about how they might start to address them. We have key people out there as well within our networks and our systems. We have scouts, champions, innovation leads, again, different names, same thing, a real extension to our networks, but embedded within the organisations that we work with. And these are real go-to people who know their organisations inside out that can help us drive and implement those changes. We are establishing databases of those needs, so each AHSN will know what their regional, local needs are, but also we'll be working to compile those needs at a national level and see where the patterns and the needs are actually across multiple regions, and therefore maybe of a national priority as opposed to maybe just a local need. And then we can decide whether, how we're going to support them. Are we going to support them by one AHSN? Are several of us going to come together to support that and do something about those needs? Or actually, should we be flagging these needs to the AAC and NICE, OLS, NHS England to work with us to try and address those needs? Some are establishing learning collaboratives. Again, these are curated spaces for those people trying to drive the change in the system to come together, have peer support and learn from each other. West Midlands are establishing membership innovation councils. So these are key leaders across their region that can come together, agree what the needs are and priorities are, and work collectively on how we should start to address them. And online platforms are going to be emerging as well. West of England have a social network platform where patients, carers, clinicians and those leaders in the system can come together and post messages, post comments, share needs to help inform that database and that information gathering piece that we're doing. In terms of the signposting, most of us are working to the innovation pathway that's been established for a number of years now. So this pathway was developed by the North East North Cumbria AHSN, and it's really a pathway of process and stages that an innovator needs to go through from idea through to successful commercialisation and adoption, and every stage in between. So in terms of the signposting, all of the AHSNs will provide support in one way, shape or form at each stage of this pathway to help innovators understand the next stage and how to progress through to a successful product. Now, how we do that and what we do, again, varies by AHSN. There are surgeries, there are themed workshops, some AHSNs run boot camps, some have bespoke accelerator programs, which may have external funding, may have external partners to deliver those accelerator programs. Again, we have dedicated people in some AHSNs who are working with the businesses to help them navigate the system. We have the national programmes that we work to, the NIA, the SBRI. So again, it might be a national programme, but the processes versus a local programme and a local support for a local SME, pretty much the same. It's still about that engagement with the system. There are a number of online platforms already established. We share one with Yorkshire and Humber that showcases adoption-ready technologies and gives some background information, the evidence and the successes in certain, where they've been adopted in certain areas, to share with people who might have the same needs and could adopt the same technologies. West Midlands have the Meridian platform, which allows people to actually post comments and concerns or positive comments around innovations that they've adopted in their region. And there are others that show videos for innovators to post a little video about what their innovation could do for the system, etc. So there's lots going on in terms of the online platforms, and other AHSNs are now looking to those platforms and looking to bring their own forward as well. We all have websites, we all have newsletters, and we all use social media quite readily. But one of the things, importantly, I think, moving forward is that we want to collate what we do, because I think the 15 of us tend to send out newsletters or information on funding calls, for example, or on events, national opportunities and initiatives to our innovators and our industry communities. But actually we could do that together probably much smarter in a much more cohesive way and reduce the duplication. So we'll keep a local flavour, but we'll work much more together nationally with those national funding bodies to do that communications around the opportunities. We host webinars, we have big conversations about big problems, again, across the system with our ecosystems, and all of us run events, workshops that are usually open to all, from all sides of the ecosystem. And some of us support and sponsor awards as well that recognise innovation and innovative practice, both within the system and within the industry side. And we don't do this on our own. The signpost in the community, the opportunity, it's a very busy landscape. So we work very closely with partners locally, regionally and nationally to do that signposting piece. We work with CRN, with the ARC clerks, as they were, the ARCs now, local incubators and clusters, industry bodies, both national and local, with our LEPs and local growth hubs. And a number of AHSNs are establishing industry councils, sector boards and industry advisory groups to help them again deliver for this programme. Quite often there's joint working, so some of the partners that you see on the right we actually collaborate with and they run the programmes with us, and in others we have funded posts within their organisations. So For us in Oxford, we jointly fund posts within the Science and Technology Facility Council to develop clusters for health tech and med tech to help support the local economy and economic growth. And Yorkshire, they're looking to fund a post within the ARC that will help with the evaluation, the validation in practice piece. And in North East, they already support a post within their CRN that helps signpost innovators around the research landscape, helps them to secure funding to do their evaluations and helps support them once they have those evaluations in progress. A challenge on the real-world validation piece is around finding that consistent model, I think. We need to stop the continuous cycle of, if you want to bring your innovation in here, you need to do a pilot with us first, when you've already done 10 pilots with 10 other AHSNs, and it still happens. So we need to find a robust way of running evaluation of products, innovations in a real-world setting, gathering robust evidence that can be deployed and accepted by other regions without the not invented here syndrome being thrown back at us all the time. So there's been a group established to do that, and it includes health economists, methodologists, people from more of a research background, as well as those people in the system, the AHSN network, working with the businesses and the innovators themselves to come up with a really practical way to run those real-world validations, but that one that will deliver robust evidence for adoption and spread. We'll support those innovators that do develop that evidence and get that impact evaluation done to really shape the value proposition in the language of the system. So often we find innovators and companies come to us and they've developed a business case or a reason why this product is the best thing since sliced bread and should be adopted by everybody, but actually the narrative to the system is all wrong, and they're not approaching the system in the right way. So a key part of this will be to articulate how that innovation can really support the system side and system transformation. And then once we've got that sorted, it's identifying then what the barriers are, because again, we all know, those of us within the AHSNs or those of us trying to bring innovations in or those of us trying to get our innovations adopted, the barriers can be multiple and varied, and they can vary from place to place. So we really need to start talking to each other about those more collectively as 15 AHSNs, what's worked, who's been able to address those barriers, and support each other to drive those barriers down, to drive the adoption. And then once we've got that evidence and that knowledge, we can then put together implementation toolkits that we can share with each other. So it's more of a guide of the how to get this into your system then, with the evidence, with the barriers addressed, and with the good practice that's been developed in other areas who have already adopted. So again, how we're going to do this, we vary. There are different models in different areas. So there are some that, as well as having the national test beds, are establishing local test beds and demonstrator sites with trusts, with GP practices, etc., so that we can have places to put the innovations and really develop that evidence base. There are patient consent models and linked patient records at system levels that we're looking to use to bring the innovation through and gather the data of the impact. Some AHSNs are setting up innovation councils, evaluation hubs and panels to look at the best innovations and the evidence behind them. We have NHS-sponsored incubators and accelerator opportunities. And again, as I mentioned before, there's a range of experience now being recruited into the AHSNs directly and or set up through collaborations and subcontractors to bring that health economic, analytical and methodologist skill set to the AHSN networks. We will continue to build on our collaborations with partners such as the Clarks, the CRNs, and the academic health science centres, who are maybe more in the research space than we are. So we work with them to bring that research, translational research, into practice. Some AHSNs are planning to fund the implementation and adoption and the evaluation side of the programmes. So some will fund dual running in a change in service, so they'll maybe fund additional staff to run services in parallel while the change is happening. Some will fund the implementation, the cost of the products, and some are funding evaluation with local universities, etc. And others are supporting access to funding, so helping the innovators find the funding to run their evaluations. And again, there are online platforms being established by some specifically around this evaluation piece. In terms of the spread and adoption, as I said, we're all taking a whole system approach. This isn't one product for one hospital. This is around trying to bring system change. And some AHSNs are taking a very broad view of how to do this. So they're looking at lots of needs and priorities within their STPs, identifying those needs and classifying them, and then looking out to the system, to the commercial sector to identify potential solutions and then do some matchmaking. So doing that horizon scanning to bring solutions to our STPs. Some AHSNs are doing a real deep dive into some of the real meaty problems and needs and priorities and picking 1, 2, 3 or 4 key themes. So Eastern AHSN are currently looking to do a whole health innovation exchange around suicide. So doing a deep dive into the real needs in their system, looking at the problems, articulating those problems out, doing the horizon scanning to look for potential solutions, bringing those solutions into the system, running the evaluation on them, and then they will look to do the spread and adoption on those that prove successful and impactful. So different models, but we'll learn from each other and we'll learn what works well and what has the most impact and brings the most change. There are a number of frameworks being established, task and finish groups, and again bringing those multiple stakeholders, because AHSNs on their own can't drive this change. We can't drive spread and adoption. It's the hardest piece of the innovation landscape to achieve, and we need buy-in from all our stakeholders. To help us work collectively and learn from each other, we've established an online forum that we all use to share, to talk, to chat, to post and to showcase what we've achieved. And we'll all be working collectively on the national programme of the AAC, where there'll be a small number of designated transformational products that all 15 AHSNs will be supporting the adoption of within their regions. Some AHSNs are very active in supporting spread and adoption outside of the UK as well, and working with Healthcare UK and DIT to support businesses to take their products from the NHS, from the UK out overseas, Europe and to the States and to the Middle East. And I think one of the key initiatives that North East North Cumbria are leading on for us is actually bringing together a database of everything we're all doing, who we're all working with, which businesses we're all supporting, how we're doing it, what stage of support we're at with them. So we'll all be able to see what each other's doing and how we're working with those businesses, and importantly be able to see what innovations are out there that we're managing to bring into the system. We'll do an annual review. We'll survey all of those businesses each year and ask them to report to us what difference we've made through the local and the National Innovation Exchange activities. Report to us on jobs, on export activity, report to us on increased revenues. And we'll also then develop those exemplar ones where we've really been able to make a difference, and into case studies that we'll showcase locally, nationally and hopefully internationally as well. So that's a bit of a flavour of how we're all going to do it. There's a lot more detail behind it than I've been able to go into today. But while we're all busy implementing locally and delivering our local innovation exchanges, we're not going to lose sight of the fact that this is a national programme, and the 15 of us will be working very hard collectively to make a real difference in this space. And to that end, we have appointed a national director for the innovation exchanges to work with the 15 of us and make sure that we do get that critical mass and that sharing going on, so that we really do achieve together and at scale. And that post, I'm thrilled to say, has been filled by Karen Livingstone. So I don't know whether, Karen, you want to add anything, or...
I don't know if are you wrapping up a little bit more on adoption? Okay, so I guess the role in terms of bringing some national coordination, as you can see, it's quite complex, fragmented landscape, and we want to be able to reflect the breadth of the offer and the appropriate locality relationships, but also a coherence around how we work together, deliver a more systematic process in terms of that accelerated access, and change the landscape in terms of innovation, but also most critically in terms of our patients and users. So as yet, I haven't even started in the role yet, 2 weeks away I think. We don't have all that infrastructure at a national level, but that's partly what we've got to now get on and create. As Lorna set out for you, we do have an awful lot of commonality, and there's an awful lot of coherence around how we are working. Important processes will be about making sure we're clear about where we are consistent and how we're describing that, creating perhaps a more systematic front door for people who are bringing innovations to that they want bringing into the NHS, but then equally from the NHS's point of view, putting a clear mechanism for us to articulate our needs, and make it clear to that sort of wider innovator community what we're looking for in terms of change and solutions. So some of those processes very much watch this space, and we'll be trying to develop them. Some of them it will be about supporting the local systems to keep on delivering as they are, but bringing just perhaps a little bit more of a framework and coherence to how they're working collectively. And hopefully, as Lorna said, the overall ambition is to change that landscape in terms of patient care, but also to support economic growth in our businesses and our communities to get the value out of working with the NHS in terms of changing care for patients. I think that's probably enough for me now. I'm happy to pick up questions.
Okay.